I've been asked to discuss today, or rather show to you, as many of you already know, that the Roux-en-Y gastric bypass is here to stay and should be the operation of choice. Before I start, I want you to know how many in the audience are bariatric surgeons? Good. And how many of you still do gastric bypass? And how many of you do sleeve, manga? Okay, good, because I'm going to, and then stand up. 0. Good. That makes it easy. I got the easiest of all the lectures today. And here's why. Gastric bypass was developed in 1966. It's been around for almost 50 years, and we still practice it today. Tell me another bariatric operation that we practice today after 50 years. There isn't one, and there's a reason for that. It works. The sleeve gastrectomy, it was first developed in 2003, and it wasn't developed as a definitive operation. It was developed as a staged approach for high-risk patients, if you remember, when Michel Remy first did this in his approach to patients with orthodontal switch. And then we all took it over and started applying this concept, and over time, it gradually became more and more popular. However, it is still a very short track record. It's still too early to make any long-term predictions, especially if you're going to compare it with an operation that has a 15-year track record. And so this becomes a factor when we counsel patients on how to choose the best operation. And this operation also is not standard. It has undergone a lot of changes over the years. The bougie size has changed, the distance from the pylorus has changed, the staple line, do we oversew, do we put a buttress in, do we leave a fundus, a small part of the fundus to prevent leaks, do we take it all away? There is no standardization. It is an operation that is still in evolution. So definitely we cannot say that it is the operation of choice because we don't have a standard operation yet. And it's deceptively simple. This is why it's so appealing to many of us, because it's such a simple operation. All we do is just resect the stomach longitudinally alongside the bougie. But there are many technical pitfalls. It's simple in concept, but technically complex. Meaning, you have to make sure the gastric walls are perfectly flat so that the staples engage perfectly, or else you get a leak. If you get a leak or staple line failure in these patients, it's devastating. There's always the potential for narrowing the sleeve too much, and then you get a stenosis in the incisura, and you know how patients suffer from that. Or if the stomach tube is not perfectly straight and it spirals. And so all these are problems that we have to deal with. The leaks especially, you know how hard they are to treat. You know how patients become critically ill, end up in intensive care, and most will need intervention. Most will need intervention, and this is in comparison to what we thought was a devastating complication in gastric bypass when they had an anastomotic leak. But you know what? That is so easy compared to these patients. And then let's not forget also the association of sleeve gastrectomy with gastroesophageal reflux. We're actually advised to not offer sleeve gastrectomy for patients with GERD because of the generation of high intragastric pressures and because of the change in the anatomy of these patients. And frankly, many patients tell me they don't want to have parts of their bodies removed. They don't want to have healthy organs excised. So I think I've shown that the gastric bypass is much easier than the sleeve. What about the band? Well, we just established nobody here uses the band, but this is a paper that's just about to come out in SWORD. It's available online. It hasn't been published yet. And this comes from the Netherlands, where the arts group, they followed the patient, 200 patients for nearly 14 years with 99% follow-up. And the gastric band was removed in 53% of patients. Of the rest, 50% had bad satisfaction scores. Only 22% out of these 200 were satisfied with their band. And 47, nearly half of the patients had complications, and nearly 70% of them had reoperations, whether to remove the band or to reposition the band. So the band really, I think, is dying. Well, you might wonder about some of the data. I haven't shown you any data. Well, you know Walter Flores was one of the big pioneers and authorities on the gastric bypass, and he was the first to report long-term follow-ups on his patients. And you can see there, very satisfactory weight loss at 15 years. And then came Calvin and Fresno, and he also followed up his patients for 10 years, and he also reported very acceptable excess weight loss of 57%. And it is safe. When we compare gastric bypass with other operations, common operations such as colectomy, hysterectomy, cholecystectomy, you can see how the complication rate and mortality rate is so safe compared to. What about its effect on metabolic syndrome? So this is a recent review from the old database that we have in the United States from the Centers of Excellence days. Nearly 200,000 patients, 12% of them were diagnosed with metabolic syndrome. 62% of them had gastric bypass, which was at the time by far the most popular operation compared to the band and the sleeve. The sleeve at the time is not represented well here, it's only 4%. But when we look at the comparison of the band and the gastric bypass and the sleeve, and the judicial switch with BPD in this patient, in this population, you can see that the gastric bypass patients had by far much better effects on hypertension, diabetes, and dyslipidemia. Not as well as the BPD, Scopinaro's operation and judicial switch, but obviously with much better safety profiles. And most recently, Phil Schaller presented a very good study, the Stampede trial, which was presented earlier today, where it compared the best medical treatment versus gastric bypass versus sleeve. And you can see the numbers in yellow there, the results. The gastric bypass patients, 42% of them reached normal blood glucose, and another 42% had complete or incomplete resolution. Nearly 70% of them had, and this is far superior to the sleeve gastrectomy. And again, this depicts how surgery in general, but particularly gastric bypass, had better outcomes than medical office. These are more comparative studies comparing gastric bypass outcomes with either the band or the sleeve, and they once again show marked superiority of the gastric bypass. So in conclusion, the gastric bypass is an established operation with a proven track record. It carries a very good safety profile and efficacy. It is ideal for diabetic patients. Its complications are relatively manageable, especially with diagnosed curves. The sleeve operation has technical pitfalls, complications can be devastating, and there is too much of a price to pay for weight loss that is equivalent to adjustable band. And of course, we know the band is dying, the sleeve gastrectomy is still evolving, and therefore, the gastric bypass should be the operation of choice. Thank you.
Bueno, ahora el doctor Raúl Cabo, coordinador del área de cirugía bariátrica del Hospital Español en La Plata, Buenos Aires, nos va a hablar de bypass gástrico, ¿por qué no? Muchas gracias, doctor.